Hello, everyone. This is Dr. Mohammed Salman. I'm a consultant pediatrician, and today we'll be talking about the diagnosis of allergic rhinitis in children. So basically, this presentation is going to be talking about what is allergic rhinitis, the pathophysiology of allergic rhinitis, epidemiology, diagnosis and assessment, and classification differential diagnosis of allergic rhinitis in children. So what is allergic rhinitis? So it's important to know that allergic rhinitis is an atopic disease. It's an allergy, as most pediatricians will know, presenting with symptoms. There are main symptoms and secondary symptoms. The main symptoms are usually sneezing, nasal congestion, and usually the mother says that the child has a blocked nose, clear rhinorrhea, and usually it's expressed as a runny nose, and nasal pruritus, which is a nasal itch. Other symptoms also may occur like conjunctivitis, eczema, asthma, chronic rhinosinusitis, otitis media with effusion, and sleep obstruction. So does allergic rhinitis only impact the nose? The answer is no. The nose is the main impacted organ. However, other organs also may be affected in some patients. So this is important. When a patient or when you see a child and you have to check for other symptoms in other affected organs. So the inflammatory reaction could involve the mucous membranes of, as we said, the nose, eyes, Eustachian tubes, middle ears, sinuses, and even the pharynx. So what's the pathophysiology of allergic rhinitis? So mainly it's divided into two phases. There's an early phase and a delayed phase of an inflammatory reaction. So allergic rhinitis is an IgE-mediated response to an allergen. So whenever there's an inhaled allergen the child is exposed to, this starts the cascade of the inflammatory reaction, which starts with the IgE mediated response. So the early phase triggered by IgE mediated response, the IgE mediated response triggers inflammation of the mucous membranes, and it's driven by type 2 helper T cells and inflammatory mediators, as we're going to mention now. So also it's important to understand that the tendency to develop IgE-mediated reaction itself has a genetic component. So usually a past history of parental or any family history of atopy, not only allergic rhinitis, is very important when you see a child with allergic rhinitis. So as we mentioned, the initial response is once the child is exposed to an allergen, the response occurs within 5 to 15 minutes of exposure. Specific IgE coats the surface of mast cells, which are present in the nasal mucosa. As we can see in this picture, this is a picture of the mast cell, and the mast cell has on its surface allergen-specific IgE. When this allergen-specific IgE is exposed to an allergen, the mast cell degranulation occurs, and it occurs when it binds to an IgE on mast cells. So what happens when degranulation occurs? Degranulation of mast cells leads to immediate release of a number of preformed and newly sensitized mediator, both of them, including histamine. And this is the most important mediator that's secreted by mast cells in allergic rhinitis. So it's followed by tryptase, chymase, kinins, heparin, leukotrienes, and prostaglandin D2. So if you can look at this picture, we can see the allergen exposed to the nasal mucosa. So the mast cells with the IgE-specific particles on it also causes the degranulation of chemokines of mast cells, releasing chemokines, histamines, TNF interleukins, prostaglandins, and leukotrienes. And chemokines, tumor necrosis factors, and interleukins also aid in the late phase or the delayed phase reaction. So the early phase reaction mainly causes symptoms, which are the popular symptoms that all doctors know of, which are rhinorrhea, sneezing, nasal itching, eye redness, eye tearing, and mild nasal congestion. However, we have to understand what's the pathophysiology of these symptoms and what causes it. So sneezing was found that histamine induces sneezing through the stimulation of the trigeminal nerve, while rhinorrhea Histamine stimulates mucus gland secretions, and plasma exudation occurs due to increased vascular permeability of the nasal mucosa, while nasal congestion and increased ear pressure is mainly due to vasodilation. So it's important to understand why these symptoms occur and treat or manage the pathophysiology rather than only managing the symptom. So this takes us to the delayed response, which occurs after 4 to 8 hours of the initial phase. And these mediators recruit other inflammatory cells as histamine. They recruit other inflammatory cells to the nasal mucosa, including neutrophils, eosinophils, B lymphocytes, and macrophages. Late phase response is a result of the continued inflammation and produce symptoms similar to the early phase. However, there's less sneezing and itching. So it's very important to ask the mother specifically about the symptoms that's currently occurring, not what started only. And there's more congestion and more mucus production throughout the delayed phase. And the late phase may persist for hours or even days, as we will mention later on. And as we can see, this is the inflammatory cell recruitment, chemokines, tumor necrosis factor, interleukins, all call for eosinophils, basophils, and B cells, which also triggers a cascade of inflammatory response. So what's the epidemiology of allergic rhinitis? So it's very important when you're dealing with a child and you suspect allergic rhinitis to understand a couple of facts related to the epidemiology. So is it a rare disease? What's the frequency of allergic rhinitis? So the prevalence of allergic rhinitis may vary within and even among countries. So it varies from one country to another, and even in the same country from one region in the country to the other, depending on the geographic differences. So it's very important to understand the culture and the geographic circumstances that you're working on. So if you're working in a city with a high population and high pollution, it quite differs from a desert area. And if you're working in a coastal area with high humidity, is quite different than a dry area. So you have to understand where you are working or where the patient is coming from to understand the impact of this geography on allergic rhinitis, the types and potency of different allergens. So is this patient living in a farm and exposed to a high rate of pollens, or is living in, for example, near a factory and it's impacted by the fumes that are coming out of the factory? So also the types and potency of different allergens and the overall alloallergen burden. So this is the first thing. The other thing, it is a frequent disease. So allergic rhinitis affect about 40 million people in the US alone, with a 20% cumulative prevalence rate. However, Scandinavians have a less cumulative prevalence rate of 15% in men and 14% in women. If we talk about race, allergic rhinitis occurs in all races, but varies among different populations and cultures. And also this could be, as we mentioned in the beginning, due to the genetic differences and the geographic factors and even environmental differences from one race to the other. Coming to the impact on sex in childhood, there were some studies that found that allergic rhinitis is more common in boys. However, in adulthood, it was found that the prevalence is approximately equal between men and women. So what about age? This is a tricky one because a lot of physicians believe that allergic rhinitis only occurs in early age and does not have an onset in adolescence or even adult age. And this is quite the opposite. Allergic rhinitis onset is common in childhood, adolescence, and even early adult years. And the mean age of onset was found to be 8 to 11 years. And of course, as we mentioned, this differs from one population and one geographic area to the other. In 80% of cases, allergic rhinitis develops by the age of 20, usually before the age of 20. So it's very important because we get that question a lot from our patients. So if the patient, if we have a child, for example, 10 years old, and they mention that this is the first time they have these symptoms, or it's only began from 1 year ago, and they're asking, could he be free of allergic rhinitis when he was young? and now develop allergic rhinitis? And the answer is yes. It's very important to make that clear for parents who ask. When we talk about mortality and morbidity, allergic rhinitis often coexists with other disorders such as asthma, and this is very important and could be associated to a large extent with asthma exacerbation. So AR itself is not life-threatening. So when a mother asks, could it cause death? By itself, it does not cause death unless accompanied by severe asthma or severe anaphylaxis. And the morbidity from the condition can be significant, and we will mention that later on in this presentation. So how to diagnose allergic rhinitis, and this is very important for all physicians who deal with these patients. So any physician complaining of symptoms of allergic rhinitis, you have to consider four main pillars. So what's the history and symptoms of recurrent or persistent rhinitis? To ask about the signs of atopy and recurrence or persistence of rhinitis, the demonstration of IgE allergy and exclusion of other causes of rhinitis, of course. So if we take them one by one and we mention, for example, the history, you have to ask about these questions. So first question is, what's the onset and duration of the symptoms? You have to look for a pattern in the child. So when did it start? How did it start? How frequent is it? This is very important, and also it aids in the classification in allergic rhinitis. We will talk about this also later. And also the treatment depends on this classification of severity or recurrence, of course. And you have to ask about the triggers for symptoms. So this is one of the main key factors of management when you're dealing with allergic rhinitis. So what is causing the trigger? What's causing the inflammation? What's causing the reaction? So you have to look for the allergen, and this is actually a very important, and it's time consuming and needs to be done in the first few sessions of treatment. So you have to have a list of all allergens that the child could be exposed to and ask about them one by one. Do not ask the patients what the patient is exposed for. That's a very general question, and usually parents are not, they don't have the answer on top of their mind. So take them closely and one by one to all allergens the child may be exposed to. The third thing is, what is his or her response to medications? So if we're talking about a patient with allergic and known diagnosis of allergic rhinitis, so it's very important where we stand. What medications are they on? Do they improve with nasal steroids? Are they maintained on nasal steroids, or they're not on it? So it's very important to understand the history so you can evaluate correctly and base your management also correctly. The other thing is comorbid conditions, and this is a huge mistake that a lot of doctors fall in. They do not look for other comorbidities. So it's very important to look for asthma specifically, and we're going to talk about comorbidities as well. So not only asking about nasal and allergic rhinitis symptoms, but please ask for asthma symptoms, especially asthma exacerbations. So when we're talking about family history also, it quite raises the suspicion index, and we see it a lot. And we ask the parents, does one of you have a history of allergy? We usually find one of them raising their hand and saying, yes, I have asthma. I used to have allergic rhinitis when a child. I used to have skin allergy and other types of allergy. Environmental exposure is very important. So you have to understand, as we mentioned, where they live. So you can understand what is the impact of their surrounding environment and what types of aeroallergens are they exposed to. Another thing in history you have to ask about is the effect on quality of life. Please do not forget this. Please ask about their sleep pattern, and ask about their school grades and their attention in school. And all this, it's the quality of life that we are trying to achieve when we are treating allergic rhinitis. Not only we are trying to eliminate symptoms. So also when we're asking about the disease pattern, you have to understand what was the age when symptoms started. Were the symptoms continuous throughout the year, or were they recurrent, for example, seasonal since onset? And are the symptoms present all day or only at specific times during the day? Also, this helps you recognize the pattern and helps you understand the current situation and the classification of allergic rhinitis in this child. You have to ask about trigger factors, and this is very important. And I believe if you are a physician or a pediatrician that deals with a lot of cases of allergic rhinitis, it's very important to have a checklist of triggers that you ask one by one and not to miss anything. So triggers include pollens, mold spores, specific animals, dust, smoke, pollution, strong smells. This is just an example of all triggers that can cause allergic rhinitis in children. So please ask about them one by one and take your time in identifying the trigger, because once you know the trigger, and this will be a major point in your management plan, just to avoid this trigger will cause the patient to be much better. So you have to ask about comorbidities, and we mentioned asthma as the main comorbidities, but there are other atopic conditions, including asthma, atopic dermatitis, allergic conjunctivitis. You have to look for nasal polyps, and this is quite tricky because there is a controversy if nasal polyps is a comorbidity or even a complication for allergic rhinitis, but you have to make sure is it present or not. You have to ask about sinusitis, ask about otitis media, and once we found otitis media, it's quite a dilemma, because once a patient has allergic rhinitis and otitis media once, usually it's recurrent. And also there's a debate if it's a comorbidity or even a complication from allergic rhinitis. When you ask about complications, and we're talking about the impact of allergic rhinitis on social inconvenience, on sleep pattern, and if it really causes sleep disturbances and obstruction if the child can't breathe properly from their nose. And sleeping disturbances and psychological inconvenience also impacts learning difficulties, impaired maxillary growth if it's left untreated. Dental problems also is an issue. And allergic rhinitis itself, if left untreated, it can cause a series of infections, including conjunctivitis, rhinosinusitis, and otitis media. So as we can see in this figure, there are direct comorbidities like upper respiratory infections, conjunctivitis, severe asthma, atopic dermatitis, chronic rhinosinusitis, and otitis media. And this causes another circle of decreased quality of life, emotional disorders, sleep disturbance, inattention, and reduced short-term memory, family, social, and behavior problems, and mouth breathing, of course. And please, 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 allergic rhinitis is not a disease to underestimate. You have to manage it properly and make sure that both parents and the child are satisfied and having a good quality of life. And in the next presentation, we will be talking about management of allergic rhinitis. So family history is a very important question and a very important topic to discuss with the parents. And we're not talking about only the parents. You have to ask about if there's any positive family history for atopy. And this quite makes the diagnosis more likely due to the genetic impact or genetic factors that cause allergic rhinitis or IgE-mediated inflammatory response. So ask if both parents are atopic, because if both parents are atopic, this has a greater risk of allergic rhinitis diagnosis in their child. And don't forget that a child with no family history of atopy can also develop allergic rhinitis. So if all family are free, this does not mean that the patient does not have allergic rhinitis. Ask about exposure. We're talking about environmental exposure to identify the specific allergic trigger. Ask about risk factors for dust mite, for example, exposure, carpeting, heat, humidity. Risk factors for mold exposure, for example, dampness. So each exposure also has quite some risk factors that you have to identify and make sure you eliminate in your management plan. So what are the main symptoms of allergic rhinitis? We mentioned them in the beginning of this presentation. We're talking about rhinorrhea, nasal congestion, postnasal drip, which is quite an issue, nasal itchiness, and sneezing. And usually the mother comes and says that she has a persistent cold or persistent infection that's not going away, and you have to raise the suspicion of allergy or allergic rhinitis and discuss this with the parents. So are there other symptoms of allergic rhinitis? Yes, absolutely. There are other symptoms that may occur. Itching in the eyes, ears, palatal. Also itching, headaches can occur due to allergic rhinitis, earache, tearing, red eyes, eye swelling, and fatigue and drowsiness and malaise, of course, occurring with less sleep, especially in children. So if you have symptoms suggestive, there are symptoms suggestive of allergic rhinitis that you must be aware of. And there are symptoms also usually not associated with allergic rhinitis. So if we're talking about symptoms that suggest allergic rhinitis, you have to look for, as we mentioned, the previous symptoms. And usually it has to be 2 or more of these symptoms and more than 1 hour in most days. So if a patient mentioned that they had a sneezing and for a couple, the child was sneezing for a couple of minutes in the morning, and this occurred, for example, 2-3 days ago, it's not suggestive to be allergic rhinitis. However, if it's more than 1 hour and accompanied with rhinorrhea, it raises the suspicion of allergic rhinitis. And the more symptoms that occur, also the more likely this patient or this child is diagnosed with allergic rhinitis. And from that point, you have to assess the severity. However, there are some symptoms, if you hear them from the patient and they are the main complaint from the parents, it's very important to exclude allergic rhinitis. However, they by themselves are not common in allergic rhinitis. So if a patient has only nasal obstruction without other symptoms, mucopurulent rhinorrhea, not clear or watery rhinorrhea, posterior rhinorrhea or postnasal drip with thick mucus and no anterior rhinorrhea raises the suspicion that this could not be allergic rhinitis. Pain also is not one of the symptoms of allergic rhinitis. Recurrent epistaxis, and this is quite tricky because sometimes patients with allergic rhinitis have episode of epistaxis. However, recurrent epistaxis as the main symptom usually is not allergic rhinitis, and of course anosmia is not one of the symptoms of allergic rhinitis, and it's very important to know the cause of these symptoms while diagnosing the patient. So what's the workup of allergic rhinitis? So it's quite straightforward. If the patient has a straightforward history, there are no need for any investigations or any studies for this patient. However, if the patient is difficult to diagnose and you as a physician or a pediatrician do not know the diagnosis, it's very important to use some investigations could be ordered. Most importantly, a skin prick test, a serum, allergen-specific IgE test, a CBC count with differential to see if there's a rise of eosinophils or eosinophilia in this patient. Total serum IgE, also there could be an increase in total serum IgE, CT scan for sinusitis, and rhinoscopy for nasal polyps. However, we're going to talk about only 2 tests. First, the skin prick test, and as you can see from the picture, it's a non-invasive test, a simple test, a fast test, and also a cheap way of identifying allergens. So The objective of skin prick test is to identify the causative allergen in this patient to help aid the diagnosis and also aid in the management by eliminating the exposure to this allergen. So, of course, it should be done by a qualified allergist. It's very difficult to be done by a pediatrician and unspecialized in this area. It's highly sensitive and specific for allergens to diagnose allergic sensitization, and it remains the fastest. It takes about 15-30 minutes to know its results, and the cheapest way of identifying allergens if we are comparing it to serum IgE specific test. So the skin prick test also results should be correlated with clinical presentation, and this is very important for all physicians. So if you find the patient, for example, allergic to a certain trigger, and by family history or by his past history, there are no triggers of this kind whatsoever, you have to correlate both the test with the clinical presentation and past history exposure, just because of the high rates of false positive results that we see with skin prick test. And don't forget to stop advise the patient to stop antihistamines about 1 week before the test, because it will impact the results in this child. The other test we're going to talk about is allergen-specific IgE testing, and a test that measures different serum IgE levels of various allergens. And also there is a false positive and negative result rate that can be due to cross the activity, the age of the patient, or the type and duration of exposure to the allergen. And when we have a small comparison between immunoassay versus skin prick test for diagnosis of allergic rhinitis, immunoassay is not influenced by any medications, not influenced by skin disease, does not require experience, quality control possible, and it's expensive when it's compared to skin prick test. So skin prick tests are cheaper, have a higher sensitivity. They give immediate results, as we mentioned, less than 30 minutes, and requires expertise to make this test, especially in children. So if we're going to talk about allergic rhinitis classification, we have two types of classification. We have a very simple type describing the response and the pattern of the allergy. So if the allergy is triggered by seasonal aeroallergens, for example, like pollens in the spring, we call it seasonal allergic rhinitis. We call it perennial when it's a year-round allergen, not related to a specific time of the year or a specific weather. For example, if the patient is exposed to mold, dust mites, and animals. And animals also is quite tricky when the family has a pet and they are quite attached to this pet. This becomes an obstacle while management. And there's also episodic, which is only a response to in a quite short duration. For example, if we are exposed to a friend's pet, for example. The other classification, which is very important, that all pediatricians and all physicians know are which is this allergic rhinitis intermittent or is it persistent? So it's intermittent if it's less than 4 days per week or less than 4 weeks per se, and it's persistent if it's more than 4 days per week and more than 4 weeks in a total duration of symptoms. And this takes us to the symptoms. Are they mild, moderate, or moderate severe? Mild means that the child has normal sleep, there's no impairment of daily activities, no impact on sport, there's normal work and school, no troublesome symptoms, and this is considered a mild patient. So if a patient has mild symptoms and is less than 4 days per week or less than 4 weeks, this is considered a mild intermittent case. However, moderate and severe symptoms or classification of allergic rhinitis These children have abnormal sleep, have impairment of daily activities, of impairment of being able to do any sports, abnormal work and school conditions, and troublesome symptoms. The patient even has one of these symptoms. This patient is considered moderate to severe. And again, we correlate it with is it intermittent or persistent? And this will aid us also in the management will we talk about in the next presentation. So the last thing we're going to talk about is excluding other causes of allergic rhinitis, and this is by knowing the differential diagnosis of AR, and other causes of rhinitis in children are, the first thing is infection. You have to exclude that there's a viral or bacterial rhinosinusitis. You have to exclude that there's a nasal foreign body, and you have to make sure that there is no physical or chemical induced rhinitis. Drug or food induced rhinitis also could be in these children, and vasomotor rhinitis. Once you exclude all these and ask for the 4 pillars in diagnosing allergic rhinitis, you will have a preliminary diagnosis of allergic rhinitis. The next step is to put a clear classification for this patient from their past history, and begin the discussion with the parents of their condition and the management plan that we will discuss. Thank you very much for listening to this presentation. Thank you for your time. I hope this helps you in diagnosing children with allergic rhinitis. My name is Mohammed Salman. Please send me an email if you have any questions or any feedback. Quite welcome. Thank you very much.